Hi guys, welcome to the immune system lecture. We're going to talk about a number of different aspects of the immune system and how we can manipulate that pharmacologically. There'll be a focus on a couple different groups of drugs. First would be corticosteroids, and also we'll be talking about anti-rejection medications, mostly in the sense of solid organ transplant. To review the immune system a little bit, these are some slides you can come back to, and I think they provide a good visual for where things work. You can see this is a T cell here, and you have an antigen presenting cell here, and the artist has drawn a number of shapes in here that act as different types of receptors. And really the only point in looking at this is to know that there's a lot of different moving pieces in a T cell. So if we want to inhibit some form of T cell activation, there's a lot of options available to us pharmacologically. There's a couple that have stood out as drug targets though. And these little things that look like text boxes they've inserted here are basically the big ones. Some of these are really not relevant, and like these things not super important, but for example, like calcineurin inhibitors, cyclosporin and tacrolimus are big ones. Azathioprine is a classic one. Sirolimus, everolimus, those are also important drugs in this area. So there's a lot of different ways we can do this, and the only point is if you like a visual way to look at how things are moving around. When we talk about mechanism, you can refer back to this. So we're going to talk about a couple different aspects of the immune system. So when it comes to the innate immune system, this is your first line of defense. It's not a learned or adapted thing, and it's designed to protect the host before an adaptive immune system has a chance to kick in. So of course, if you've never been exposed to some sort of an antigen before, you're at risk for getting some sort of disease from it, or some sort of, whatever it might be, if it's an infectious component, bacteria, virus. So that's why we have things like physical barriers, we have skin, we have enzymes, serum proteins, antimicrobial peptides, we have high stomach acid in our GI tract, in the upper parts of the GI tract to help destroy things that we might not want in the body. And then we have cells that are naturally built in, macrophages, mast cells, natural killer cells, which will destroy foreign bodies, and also phagocytes. When we look at the innate versus adaptive immunity, there's a lot of shared things. So T cells and natural killer cells are kind of the shared component here. And the rapid response immunity has a number of different things. And we're going to talk about some more of these things like mast cells and some of the inflammatory processes that result from these things getting activated in coming up lectures. But for now, we're going to focus much more on adaptive immunity in T cells. So adaptive immunity is mobilized by cues from the innate system. So the innate system is encountering different antigens. It can mobilize the adaptive immunity. The adaptive immune system. B cells is what we call humoral immunity, and T cells are cell-mediated. So B cells involve antibody production when encountering a new antigen. So you get a memory of sorts, and plasma cells. So the memory is what remembers the antigen, and the plasma cells make antigen-specific antibodies, as a very basic overview of this. T cells are activated by antigen-presenting cells. They secrete cytokines, attract macrophages, natural killer cells, and they activate the cytotoxic T cells. So this is kind of a process that works in conjunction with each other. You get the different types of immunity here that help to stave off various infections. So why would we want to manipulate the immune system? Seems like most people it works pretty well. Well, a normal person, of course, is going to have an immune system that neutralizes toxins and activates viruses, destroys transformed cells that are mutated, eliminates pathogens. When we get abnormal immune system, you can get hypersensitivity, which can cause extensive tissue damage. You can get autoimmunity. There's a number of autoimmune diseases we'll cover over the year, and that's a reactivity against self-specific antigens, and usually in specific areas of the body. So like Crohn's disease, rheumatoid arthritis are examples of that. Immunodeficiency is impaired reactivity too. So if somebody's immune deficient, what can we do for those types of people? I'm not going to spend a lot of time on hypersensitivity. We're going to talk a lot more about this. We're going to talk about allergies and that aspect of inflammation and this whole inflammatory response, immune response, and all the components of it. But just to discuss what we're going to refer to, we talked a little bit about this during antibiotics, and with hypersensitivity, you have type 1, which is the most significant. It's a fast reaction. So what you think about is, you give somebody a flu shot, and all of a sudden they have a reaction about a couple minutes later. So you get anaphylaxis, hives are the two big ones. You can have milder responses, but usually there's some sort of upper respiratory involvement. Type 2 is something that is usually exposure to IgM or IgG complexes with some kind of a foreign body, so like blood transfusions, this can be common with. And it usually isn't a big deal, but it might dispose you to anaphylactic reactions in the future. Type 3, these are the common ones I just want to mention. These are skin and drug type reactions, and this is so your body is developing almost a delayed immune response. So if somebody says, well, I have this rash that came out of nowhere, I just started an antibiotic a couple days ago, and I don't remember anything else, like I haven't changed laundry detergents, I haven't brushed up against a weird plant, there's really nothing that's changed in my life except for this drug. Well, that's likely a drug rash. So that's a really common thing that we see, and that's usually a delayed response. Most people with drug rash type hypersensitivities aren't going to respond right away. If they do respond right away, that's probably more of a type 1. It's likely a little more severe than a rash, probably more hives, and again, some of that upper respiratory involvement. And then type 4 is a delayed exposure, usually a couple days after the exposure, and it's a T-cell related response. Poison ivy is a good example of a delayed response. Autoimmunity, so failure to distinguish self-tissues from foreign. It's both cell-mediated and humoral. Here's some examples of things: lupus, rheumatoid arthritis, MS, diabetes type 1, Crohn's, myasthenia gravis, just as a couple examples. We're going to talk about some of these in a lot of detail. Specifically, next semester, we'll talk about RA, diabetes, and Crohn's. Lupus is a tough one to really talk about as a topic because it's all over the place as far as how it affects people. Some people can have really mild cases of lupus or very small amounts of organ systems. Other people can have really severe kidney injury and much more debilitating effects from their lupus. But it's not something specifically that I'm going to talk about. You can suppress the immune system using a lot of these drugs we're going to talk about to prevent these types of reactions. And then you can treat using supportive care as well. Immunodeficiency, we talked about HIV and AIDS with George's lecture, and that's one of the things we're going to see. Obviously, we can destroy the immune system with drugs to help suppress it. But there are some genetic diseases, and then, of course, autoimmune deficiency syndrome, which is a T-cell mediated immunodeficiency. Before we get into some of the more significant immunotherapy or immune suppression and those types of drugs, I just wanted to touch base on a couple things because we don't really cover these anywhere else. So I just want to mention plasmapheresis quick. It's kind of a cool therapy if you've never heard of it. What basically it does is you remove plasma plus whatever foreign antibodies are in the body and replace it with non-antigenic plasma. So replace it with plasma that's been specifically screened to not have any antigen containing or not a product that doesn't have any antigens. And during that replacement process, you can remove certain circulating antibodies. So somebody has some sort of an antibody, whether it's an autoimmune disease or whatnot, you can actually treat that person by transferring plasma that way. It's kind of a cool process. Not really related to this class all that much. It's not technically a drug, but it's more of a blood product transfusion exchange type thing. IV immune globulin is something you might encounter, especially if you work in hematology oncology. And what this product is, it's actually a blood product. So they've extracted IgG antibodies from whole blood after donations or things like that, or plasma donation. And then what this is doing is it's supplementing your body's own IgG antibodies. So you're augmenting somebody's immune system for those who are suppressed. You can get complexes that cause overall anti-inflammatory effects. And so this is used for a number of indications too that I'm not really going to go into detail on too much. If you want to read on it, On your own, I'm not really going to test you on these things on this slide. I just think it's worth mentioning, and because you might see it again, especially if you go into hemonc, you'll see these types of therapies used. Multiple sclerosis, I just wanted to mention too, because it's a really tough disease to treat, and there's a ton of money being spent in this area right now. So there's a couple different drugs we can use, and I'm not going to test you on MS, so this is just sort of a bonus slide for your information type thing. But we have a group of drugs called interferons. The mechanism is not totally known, but they're thought to suppress T cell activity and reduce inflammation. So when you have multiple sclerosis, you're getting inflammation of the myelinated sheaths in the central nervous system. And what you have is an autoimmune disease that attacks different parts of the CNS, and then you end up with lots of issues because of it, whether they be movement related or other. And this can basically, interferons being used to suppress the immune system on a broad spectrum way. There's some chemotherapies that can use, but there's a lot of new drugs coming out on the market. There's a couple examples I have here that work on the nerve cells themselves to, for example, blocking potassium channels, which prolongs your action potential between different neurons. And Tecfidera has anti-inflammatory and cytoprotective properties to respond to the oxidative stress going on that's causing the destruction of these myelinated sheaths. So if you work in any type of specialty that sees MS patients, just know that there's a lot of drugs out there. They're super expensive. It's a very specialty area, and certainly you can treat people, but know that there could be some red tape to prescribing some of these medications. But again, I just wanted to mention this because we don't really cover it anywhere else, and it sort of fits into the realm of the immune system. It's one of those diseases that there's a lot of options for. None of them are very good right now. We have a number of other autoimmune diseases we'll talk about that are much more fleshed out as far as treatment strategies. With MS, there's not a lot more I want to say about it than this. If you've read in the news anytime recently about immunotherapy, and what I like to think about is futuristic stuff that's pretty cool. What we might be looking at in the future would be gene therapy and what they call immunotherapy. So the first drug was approved for acute lymphoblastic leukemia, or ALL. It's called Kymriah, which is kind of like a misspelling of chimera, which is kind of what it is. It's a chimeric antigen that they're developing. So it's kind of a cool process. What they're doing is they're harvesting a patient's own T cells, sending it to the company or the laboratory or whatever. Then they genetically modify those T cells using a specific virus they've built, which is a chimeric antigen receptor T cell, or CART. That gives the cells the ability to recognize and kill the source of the specific cancer. So it's using the body's own T cells and augmenting their immune system. And they give those T cells back to the patient, infuse them back into them, and the idea is those T cells will destroy the cancer. I think they've actually seen pretty good responses with this. I think it's still pretty new, but it's certainly promising. It's a very interesting way to, use somebody's own natural defenses and manipulate them so that we can treat the cancer. And by doing that, you're limiting your side effect approach because you're really just using the patient's own cells. Now, granted, there might be some unknowns as far as like, what's this virus you're putting into me? Is there any risk there? But that's what the clinical trials and testing are for. Of course, this isn't cheap. It's about $500,000. Novartis is the company doing this, and they've actually said that if you don't get a response in a month, we actually won't charge you for the therapy at all. So that's, drug companies aren't the most altruistic people in the world, but it's not a bad idea that they're offering this. So they're pretty confident that this is a product that is going to work. So it's something that is new. It's up and coming. I think we're going to see more of this, especially for cancers and autoimmune diseases. We don't necessarily have a better approach. Some of the drugs we're using just aren't that effective. So if we can think outside the box a little bit, like with something like this, it's pretty cool. So I think we're going to see this area growing a lot in our lifetimes for sure. All right, talking about steroids. So steroids are a group of hormones, and there's three major groups. There's glucocorticoids, mineral corticoids, and the sex hormones. So sex hormones you can immediately cross off the list for now. We aren't going to talk about these at this time, but what we will do is cover these more later in later lectures. Spring, we do a men's health lecture, and then in the early summer, we'll do a women's health lecture. So focusing on mostly glucocorticoids. Mineralocorticoids, quite different. They mostly affect aldosterone and influence salt and water balance. We'll talk about aldosterone antagonists a little bit more during cardiology. There's one mineralocorticoid out there that has very strong mineralo activity, and we'll talk about that one. So that's really the only thing I want you to know, is that one of them has more mineralo focus than the other ones. But otherwise, we're going to talk about glucocorticoids because it's primarily responsible for immune system related functions. This slide is just to show that everything steroid related is based on pretty much the same thing. So we have a cholesterol molecule, and steroids are synthesized from cholesterol in the body. And you have a number of different pathways here. So you have androgens, progestogens, estrogens. You can see everything sort of synthesized from each other. So it starts as progestogens. Those go through, make androgens, and then to make estrogens. But then again, we don't really care about this part right now. What you get is your corticosterone or cortisol. So this is hydrocortisone, and that's your basic stress steroid. So we talk about cortisol, or in periods of stress, the body is going to release this product. So that's really the end game. That's what we're talking about here. So pharmacologically, we're making analogs of this that do similar things. So again, cortisol is a major endogenous glucocorticoid in humans. Pharmacologically, we also call it hydrocortisone. It's the same chemical structure. It's just a synthetic production of it as opposed to the endogenous one, but it's identical as far as its chemical composition. Production is governed by adrenocorticotropic hormone, corticotropin, and cosentropin. So there's a number of different pathways that get produced here, but basically you have the hypothalamus that has a releasing factor, which is the adrenocorticotropic hormone, which hits the anterior pituitary gland, and then communicates also with the adrenal cortex to release cortisol. And that's really the basics behind it. I don't really want to talk about it much more than that. Getting outside my area of expertise here. More stress, higher amounts will be produced. And what really this does on a basic level is, or if you want to think about it from a self-preservation point of view, you have a period of stress. So let's say you're in a stressful situation, or whatever it might be, you're going to get cortisol release that increases blood glucose, it enhances glucose uptake, and it curbs some non-essential functions. So we're going to talk about the parasympathetic and sympathetic nervous system soon, but basically it's supporting your body's ability to shunt resources to more essential areas. So we don't need, for example, if you're in a lot of stress, or you're having a you're in a period where you actually have to defend yourself physically and really care if your body's digesting your lunch or not. You want to make sure you have plenty of glucose for your muscles to be able to use and things like that. So that's really the basic purpose of this. Now, when we manipulate this a little bit, there's a lot more to it than that. And so we'll talk about that. This shows you a little bit about short-term stress response and long-term stress response. And this is designed to be a short-term process. I mean, we aren't supposed to have lots of cortisol circulating in our body for long periods of time. It can be damaging and detrimental. But in the short term, it can be really helpful in certain situations. So again, glycogen breaks down into glucose, increase in blood glucose, your blood pressure rises, breathing rate increases, metabolic rate increases, and blood flow patterns can change slightly, basically shunting blood away from enteric blood vessels to more central blood vessels, more like the core, like heart, cardiovascular areas. What you get with long-term stress response is functions in the kidneys and sodium retention and water retention changing. So you end up with blood volume actually increasing. And that's that mineralo component that I was talking about briefly that has a more functional role in the kidneys and actually in the immune system. So we're getting a little bit off the beaten path here, but I think it's important to talk about steroids in the aspect of that they do have these effects in the body. And if you do have a long-term stress response, like if your job's super stressful and you're stressed out every day and you've got maybe a higher level than cortisol than the average person, blood volume, blood pressure can definitely increase. This can cause conversions of proteins and fats to glucose, so you can get increased blood sugar and immune system suppression. This is important to understand because, for one thing, we might want to suppress the immune system. That might be our goal here pharmacologically. So when we're giving people steroids, yeah, that's what we want. But you have to take this stuff into consideration too. So is your patient a pre-diabetic? Or they have uncontrolled diabetes? Well, this could really throw them for a loop as far as their blood sugar monitoring. I've had a number of patients who, when they're on a corticosteroid, they'll actually go on insulin while they're on it because they've had such bad blood sugar, such high blood sugar readings while they're taking the corticosteroids. So again, in the short term, there's a lot of good functions with this, but over time, buildup of stress can be really detrimental. And of course, if you have higher than average level circulating glucose chronically, that can lead to diabetes, hypertension, which can lead to things like heart failure and other complications down the road. So our glucocorticoids or corticosteroids, there's really kind of an interchangeable terminology there, have applications across a lot of different disease states. They're mostly affecting cellular immunity. They can be cytotoxic to certain types of T cells, but mostly what they're doing is modifying cellular activity. So this drawing here is pretty simplified, but what you see is all T cells will have a receptor in them that's specifically designed to interact with corticosteroids. So if the steroid hormone comes across and interacts with it, it's going to create some sort of an effect downstream, which is going to produce a new protein, and that's going to signal that there's something going on. So it's either going to suppress the activity of that T cell or make that T cell non-functional in most cases by suppressing the immune system's response. Now, with drugs, we can mimic the endogenous steroid and go through and make it maybe more potent so that it attaches more readily to a broader group of cells and suppresses the immune system a little bit better. There's a lot of allergic and inflammatory responses too. So when we're talking about immune system response, I think it's easy to think about, well, immune system, allergic, inflammatory, it's all sort of related. Remember I showed you that slide at the beginning, and you've got mast cells, which release histamine. That's an allergic response, what we'd think of. You've got immune system, which we've talked about, of course. Inflammatory is more like your eosinophils and basophils and things like that that are producing various inflammatory mediators that we're going to talk about in an upcoming lecture here. So it's all sort of related, and steroids actually have a pretty broad effect on all of those processes, not just the immune system. We're talking about it in the context of the immune system today, but we're going to talk about steroids throughout the course and how they can be used for a number of different diseases and how we can either suppress a variety of functions. So when you see the commercial on TV for Flonase nasal spray and how it works on, what did they say, 5 or 6 different areas of inflammation and allergic response or whatever they advertise it as, well, it's true. It's working on much more areas than just a simple antihistamine would, which is only working on a histamine response. So anyway, we'll get to those in a little bit here, but the point is that the steroids work intracellularly. They're specific receptors designed to interact with steroids. They complex with DNA. They produce a messenger, which creates proteins, and then you get some sort of signaling with the cell. This slide probably doesn't mean a lot to you right now, but corticosteroids can work with a couple of different aspects of inflammation and inflammatory processes. So when we talk about corticosteroids, a lot of times they're used as anti-inflammatory drugs. So here you have NSAIDs. NSAID stands for non-steroidal anti-inflammatory drugs. So NSAID is like ibuprofen, naproxen, or brand names Advil and Aleve. Those are NSAIDs, and why they're non-steroidal is because they inhibit this cyclooxygenase, which we're going to talk about in a bit. So don't worry about it too much now. But the point is that corticosteroids do pretty much the same thing. They just do it upstream, and they decrease the ability of the body to synthesize the proteins responsible for these enzymes that go on to produce prostacyclins, prostaglandins, and thromboxane. These are all inflammatory mediators. So while NSAIDs work directly on the enzyme, corticosteroids prevent the enzyme from being produced at all. And so you get a very similar anti-inflammatory process, but also a different one, and sometimes a much more potent one with the corticosteroid. There's also some issues over here with lipoxygenase, and leukotrienes have more respiratory-related inflammation associated with them, so we'll talk about those during asthma, but that can also help with shutting down the production of some of these areas too, which is why we can use corticosteroids during asthma flares. So we'll talk about all that more during respiratory, which is in the same module for this exam, but just as an introduction is how their anti-inflammatory processes work. This slide is somewhat helpful. And just to review our inflammatory and immune system, again, they are related, but they're different things, and there's different mediators that work on inflammation and immunosuppression. So depending on what you're trying to manipulate, but steroids do have a similar role in both, and they will affect both systems. All right, so talking about the drug specifically, hydrocortisone is, again, it's structurally identical to cortisol. It comes oral, parenterally, topically. You can give it a number of different ways, but basically you get 8 to 12 hours of action. It's a 1-to-1 mineralo and glucocorticoid potency, so it's similar to, so again, it's the endogenous meat substrate, similar. Well, it is the same thing, again, chemically identical. It's just a pharmacologically produced version of it. And then you have fludrocortisone. Cortisone basically considered to be the same thing. It's not, I don't know if cortisone itself actually comes as a product. I've never really seen cortisone. I don't know if it exists anymore, but just assume that you can just ignore this and consider hydrocortisone to be the one that we want to focus on. They have the same ratio, same half-life. They're pretty much the same thing. Maybe cortisone, different, slightly modified molecule with a little bit less potency. Fludrocortisone is the mineralo potency one. You do get some glucocorticoid activity, but mostly mineralo. It's very mineralo potent, and we'll talk about some ways we can use that during blood pressure a little bit. But for the most part, I'm not too worried about that for this lecture, other than just knowing that that has mineralo potency. So it's important to differentiate that steroid from other ones. From a pharmacologic aspect, because it has much different functions in how we use it. So it's going to be more related to fluid retention and things like that we're going to use fludrocortisone for. Intermediate acting drugs, methylprednisolone, prednisolone, triamcinolone. You could put prednisone in here too. This chart just doesn't have it on here. But really, these are our primary steroids, and you can see that we're getting much more heavy on the glucopotency side of things, and that's really where we want to be. This has all the inflammatory aspects. It has or anti-inflammatory aspects, anti-immune system aspects. We don't really care about mineralo for the majority of our purposes of using steroids. So unless we're trying to give somebody directly what they're missing, we use hydrocortisone. Otherwise, these drugs are preferred for the most part. And then you have some longer-acting ones, betamethasone and dexamethasone, which have virtually no mineralo potency whatsoever. They're pretty much pure glucocorticoid potency, and they're super potent compared to these other ones. Oops. So that's another thing worth knowing, is that betamethasone and dexamethasone are the two more potent ones when it comes to steroids. So when you're dosing them, you're going to dose much less dexamethasone than you would methylprednisolone. You might give somebody 100 milligrams of methylprednisolone and then give somebody 10 of dexamethasone and get pretty similar equivalencies there. All right, so hydrocortisone doesn't play a huge role in adult medicine. There's a lot of topical applications for it, and we'll talk about this during derm. So don't worry about steroids from a dermatologic aspect yet, because we'll go through that again during derm. Same mechanism, but just think about these as systemic drugs for now. You can use it in septic shock. There is some evidence that in certain cases of septic shock, the body will stop producing cortisol. And so to be able to get the beneficial effects from it, you can do a test to see if somebody's body is releasing it or not. And it's a stimulation test. So you give cosentropin, which is a molecule that should interact with the adrenal gland and release cortisol. And then you would do cortisol levels to see if they're increasing or not after you've artificially stimulated their adrenal glands. If they don't, you can consider giving hydrocortisone as a supplement. Evidence isn't great that this benefits anyone, really. There is some evidence in children that there's a benefit of giving it. And again, in adults who aren't producing cortisol on their own, there might be a benefit there. But it's usually a last line option for septic shock patients, and they aren't going to do it right off the bat. Okay, that's really all I want to say about that for now. Prednisone, again, it's very similar on this chart to prednisolone, not too much different as far as kinetics go, and potency. Prednisone is the go-to oral glucocorticoid. It gets metabolized into prednisolone, which is the active metabolite. So if you prescribe prednisolone, it does come as a liquid, and it's really pretty much 1-to-1. There's a little bit of a different potency there, but we pretty much prescribe it 1-to-1. Used in a lot of different conditions. It's a really common steroid burst product, so we give a burst of a certain number of milligrams per day every day, and then we'll stop the person. You can do extended courses. You can taper people off. It's used oftentimes as maintenance immunosuppression. We'll talk about this as a pillar of anti-rejection therapy with transplant patients. And this is a really important aspect. So one thing that we're going to come back to during respiratory is burst prednisone dosing, because it's something that's really critical for asthma flare-ups, COPD exacerbations. And the important thing is you can give usually 40 to 60 milligrams per day, and you can give about 10 to 14 days of prednisone without having to taper somebody off of it. I think people get caught up in prednisone and be like, oh, I can't give more than 5 days, and actually you can give up to 2 weeks without really having to taper somebody off. You can always taper somebody down if you feel uncomfortable with doing that, but you really don't have to. And so the point of all this is that why are we talking about tapers and whatnot? Well, what happens is if you give an extended amount of steroids to somebody for a long period of time, their body will stop making endogenous cortisol. So what happens is that once you take that pharmacologic steroid that you've been supplementing, so you can maybe you've given somebody 20 days of prednisone, and they run out or they lose their prescription and they stop at cold turkey, their body won't be producing any cortisol for a while, and it's going to take the body a bit of time to ramp that up. So what happens is you end up with adrenal gland suppression, and you can be at risk for things like opportunistic infections and things like that. You might not be able to mount your immune system response as well as you would normally. You might not be able to have that augmented fight or flight response like your body would normally be used to in a stressful situation. So it can be pretty problematic. So we do taper people, but usually you can go 10 to 14 days without having to do that, without really running the risk of adrenal gland suppression. It's when you get beyond that 2-week period that you're looking at considering a taper. And most people are doing like 5 to 10 milligrams per week, depending on how long the therapy is. And you can be more aggressive if you want, but that's a pretty common way to taper people down. So if you're doing 40 milligrams per day and you did a whole month of therapy, and you go down 35, 30, 25, 20, 15, 10, 5, and then be done after 5. That'd be a pretty common taper for somebody. And you can do faster than that. You can do like every 3 days, drop by 5. You can do sometimes daily drops. It just depends on how long they've been on it, how comfortable you are. But there's not really a right way to taper somebody. But when you do go beyond 14 days, they should be tapered off. Methylprednisolone is known as Medrol, Solumedrol, or Depomedrol. So it's available in a couple different products, and it's very similar as far as our duration of action and our potency to prednisone. So there's not a big difference between the two. A lot of times I think about it, I think even though it's not really true, methylprednisolone is sort of the IV equivalent to prednisone. And while it does come orally, it's much more commonly used IV. So again, it comes as a couple different products. There's oral Medrol, which is methylprednisolone oral. Methylprednisolone comes as this thing called a dose pack, which is a built-in taper over 6 days. So it tells the patient exactly how to take it. It says take 2 tablets before breakfast, 1 tablet after lunch and supper, and 2 tablets at bedtime. And then it tells you how to do it. The problem with this is it's not really, you don't really need to do that for any reason. It's actually making things quite complicated, even though it's all spelled out for you. What you can do instead is just have somebody on a consistent dose of prednisone for 6 days and not taper them off at all, because there's really no reason to. I think people like prescribing this dose pack because it's easy. Prescribers, I think, feel comfortable with it because they're like, well, I'm giving somebody a nice taper, so they aren't really going to be at any risk for adrenal suppression. But even if you gave them this whole dose for 6 days straight, they still aren't really going to be at risk for adrenal suppression. And it's kind of a wimpy amount of steroid overall. These are 4 milligram tablets. So you get 24 milligrams, and then you're down, 4 milligrams each day. That's not a big amount of steroid. I mean, usually for prednisone bursts, you're looking at a minimum of 20 milligrams a day for at least 5 to 7 days. So already after your second day, you're kind of at the sub-therapeutic level. And by the time you get down here, it's like, what did you really do for your patient? I'm not sure personally I buy into this being a very useful strategy, and I think it's more confusing than it is helpful. What I would do is just, if you wanted to give somebody a light course of steroids, do prednisone 20 milligrams times 5 days and be done with it, or times a week and be done with it. Don't do these weird dose packs. I just think they're not really, I don't get the purpose of them. I understand that they have some convenience and some safety things here that people might feel comfortable with, but again, I don't really get it all that much. I don't think there's a huge role for them. Slightly higher potency than prednisone maybe, but it's very similar. IV Solu-medrol or methylprednisolone is one of our most common IV steroids we use. So if somebody comes into the hospital with an asthma exacerbation or any type of inflammatory thing going on, if they have a anaphylaxis reaction, we're going to be giving steroids to help suppress that side of the immune system inflammatory response, and usually methylprednisolone is going to be our drug of choice there. It's got a pretty fast onset. And given IV and you give a pretty high dose of it, it will work quite quickly. And then it also comes as a product called Depomedrol, which I don't have on here, which is another it's a intra-articular product. It's kind of like an oil-based. It's an oil-based product that would be injected into a joint space, and that would be used for like inflammation in a specific joint, which is very similar to how we use Triamcinolone or Kenalog. Triamcinolone is probably the most common intra-articular product. It's also a really commonly used topical drug, which we'll get to more during derm. But it's not really, it does come as an IV and PO product. We just rarely ever use it. We prefer the other products, prednisone and methylprednisolone. But again, this is a really popular intra-articular option. It's considered the cortisone shot. If you ever hear somebody, a sports person or a friend or whatever, I went in for a cortisone shot, that's probably what they're getting is actually Triamcinolone. They could be getting Depomedrol or methylprednisolone as well. That's common too, but Kenalog is probably the more common product. Comes in a variety of different potencies. So you might see Kenalog 40, Kenalog 60. It just depends on how strong it is. It does cause less local post-injection flare than some other products, so people tend to like using this one. It's, again, a really popular product. And it's one that's used a lot in a variety of conditions, but specifically like if you have a person who's looking at maybe getting a knee replacement down the road and they're just at the point where their pain's unbearable, they can't move, you can maybe get them by on steroid injections, but it's not a long-term solution. It's really just a short-term fix for something until you can figure out what the real problem is. Maybe they need to do surgery or need more PT or whatever it might be, but it is not a sustainable thing. You usually get maybe 1 to 2 months of activity off of a steroid shot, and then after that you're back to where you started, and you get diminishing returns on them as well. I'll talk about this a little bit more during orthopedics, but that's the basics of it. Dexamethasone is our PO and IV drug that is much more potent than prednisone, but you can use it interchangeably with it. It's going to do the same thing. You're just going to use lower doses. So again, you might give somebody a couple milligrams of dexamethasone, or you give somebody 10, 20, 30, 40 milligrams of prednisone. Pros, you can give a lot bigger doses from a potency perspective. So let's say there are cases, and if you work in a trauma center, you might see this, but cerebral edema, if we have some sort of spinal cord injury with cerebral edema, we give really huge doses of steroids. So in that case, you can give a lot more relative steroid with dexamethasone than you could methylprednisolone. So you can give much bigger doses that way. Dexamethasone is really popular for chemotherapy and immunosuppression. It also has good antiemetic properties as well, so you get a double bang for your buck there. It doesn't interfere with plasma cortisol levels, so you can give somebody dexamethasone and still check a cortisol level to see if they're producing any. Cons, the IV onset's not quite as fast as IV methylprednisolone. Sorry, typo here. Prednisolone. So that's probably the only downside to it. Otherwise, it's a nice drug that's used quite frequently, both in its IV and oral forms. I didn't talk about betamethasone here because it's not really used quite as commonly. Betamethasone doesn't come Well, it comes as a parenteral product, but it's only IM. So we give it, a lot of times they use it in OB as an intramuscular injection, but it's not generally given IV, and I don't think it comes as a PO. So we tend to use dexamethasone a lot more. Betamethasone has some role, but I'm not going to test you on betamethasone. So you can consider just knowing dexamethasone as your primary high potency glucocorticoid. All right, so side effects, lots of them. So psychiatric side effects are one that a lot of patients will experience. You might hear about patients who get almost like buzzed off steroids. You know, you get everything from euphoria to depression to agitation to psychosis. I mean, people get all kinds of weird side effects, especially psychiatric ones off steroids. And the higher the dose, usually the worse you're going to look at side effects going to be. Most people after one dose probably aren't going to experience many side effects, but it's usually after a few that they're going to start to feel it. Physical side effects, this is really a chronic thing. So a short course of steroids over a week or two, not going to give somebody any of these. You know, months and months of immunosuppression on steroids, much more likely. So you get lipid distribution issues, including things that cause these nicely scientific terms, which is actually what they're referred to. The buffalo hump, which is a fatty deposit behind the neck, and moon face, which is basically just having a more circular face because of the way the fat's distributing. Thin and bruised skin is really common on steroids. So if you have somebody who's on an anticoagulant, that can be pretty bad because they can be bleeding a lot. Decreased muscle mass, increased abdominal fat are also common long-term side effects with glucocorticoids. Other side effects, cell growth and division can inhibit cell division and DNA synthesis, which can ultimately delay the healing process and can stunt growth in children. Again, over a couple weeks, not a big deal. Over a couple years, much more significant. Calcium metabolism. This can be actually affected acutely. Now, it's not going to likely have long-term lasting effects, but you can certainly affect this acutely. You get decreased intestinal absorption of calcium, increased renal excretion, and you can get excessive loss from some bones. So vertebral calcium wasting is common. You can end up with vertebral fractures if your patients are at risk for osteopenia or osteoporosis. Endocrine, talked about hyperglycemia already. Increased appetite is also common. So you sort of have these two aspects that affect the patient. You get automatically increases in circulating blood sugar stores, and then you get increased appetite, increased intake too, which can be increasingly problematic for the patient. Cushing syndrome is something I want to talk about. There's two quick things to mention as far as specific diseases go. Cushing syndrome is where you produce too much cortisol, and it's usually related to some sort of a tumor, either in the pituitary gland or non-pituitary tumor, but that's affecting ACTH production, and you get increased cortisol production also directly from the adrenal gland if there's like an adrenal adenoma or carcinoma. So mostly it's a cancer-related thing, but you could have other maybe autoimmune issues or possibly other responses that are causing it. Treatment is direct the primary cause, so try and treat the cancer. There's a couple drugs here that I'm not going to test you on. I'm not going to really go into more details on them, but they do work to suppress some of these processes. Super rare, not used very often outside of oncology, but they're there in case you're curious. Symptoms, most will disappear after 2 to 12 months, but you do get hypertension, osteoporosis, glucose intolerance. And the longer you have these symptoms, the harder it is to get rid of them. So if you have somebody on a month of steroids and they get really hyperglycemic, usually it's easy to recover. If you're on 2 years of steroids and you've been hyperglycemic that whole time, the damage might already be done. It might be very difficult to treat that, as opposed to somebody who's on a short course. They probably will just resolve. You probably have to treat that patient like a diabetic for long term. Addison's disease is primary adrenal insufficiency. Tuberculosis is heavily associated with this. Otherwise, it is an autoimmune disease. There's other infectious diseases, cancers, and medications that can cause it, but mostly autoimmune related or tuberculosis related. Acutely, it can cause fluid and electrolyte disturbances. So remember that we have an issue with, or our natural cortisol has the ability to have mineral component to it too. So you get fluid and electrolyte changes. that are affected by that. And if you take that out of play in the body, you can end up with things out of whack a little bit. So IV glucocorticoids is generally the replacement. Hydrocortisone is our drug of choice. You can also do a combination. You could do prednisone plus flutocortisone, but flutocortisone is going to be needed by all patients with Addison's disease because they're going to get significant changes and fluctuations in their fluid electrolyte statuses, and they'll need this drug for sure. So hydrocortisone can help with both things, but sometimes that might not be potent enough, so you might need a more potent steroid plus a more potent mineralocorticoid to be able to titrate your dose to effect better. So anyway, there's a couple options. You'd either do hydrocortisone alone or you'd try a combination. You could do hydrocortisone plus flutocortisone too to get a little bit more mineralo activity. That would be fine. Most commonly what you might see is a combination of prednisone plus a flutocortisone. So summary, just these are the ones I want you to know for the test. So beta-methazone's not on here, but you have oral options, prednisone and dexamethasone. I didn't put methylprednisolone on here because honestly, I don't think people should really be prescribing it. I don't really see its role in therapy as the dose pack. IV, methylprednisolone and dexamethasone. Potency, prednisone, methylprednisolone, dexamethasone. And again, much less space between these two than between this. This one's much more potent than these two, which are fairly similar in potency. And our mineral only is flutocortisone. So understanding this is pretty key, I think. And then, of course, knowing some of the things we talked about, some of the side effects. But that's what I'm going to be getting at for the exam material. We're going to talk about nasal sprays in the ENT-ish. I call it the ENT-ish lecture because there's some ENT stuff at the end of it. And we'll talk about inhaler as far as asthma and COPD, which these both have big roles in treating. So we'll talk about those much more in detail during those lectures specifically. All right, you can take a quick break if you want, and we'll do immunosuppressive drug therapy. You guys are like, why did he tell us to take a break? I can just pause this anytime I want. Well, maybe I just needed a break. Okay. So the last 15, 20 slides of this is going to be about suppressing the immune system purposefully. Most of this is going to relate to organ transplant. But we're going to come back to some of these things during some of our autoimmune discussions, like Crohn's disease and rheumatoid arthritis, because the suppression of the immune system applies to these specific diseases as well. So the idea is to prevent preventing cell proliferation is something you might hear about too. We aren't going to talk about this specifically right now. I mentioned it briefly during cardiovascular, but the idea is that you have, when you put a stent in somebody's coronary artery, the metal eventually of the stent matrix, the vasculature tissue will grow over that metal over time. So what we can do is create these things called drug-eluting stents, which elute a specific drug, usually a anti-rejection medication or a modified version of one that prevents proliferation of cells around that. So you might hear about that too, and there's similar drugs. And then, in chemotherapy, we can suppress the immune system for a number of reasons. A lot of that's just due to what we're trying to treat, especially with blood-related cancers like leukemias and lymphomas. Oh, and I can't forget my sign here. Be an organ donor. One organ can save 8 lives. So just think about that if you aren't an organ donor. Put a plug in for that right now. Transplant goals of therapy. So we want to stop the body from destroying the transplant organ. We're going to talk about mostly host versus graft at this point, and that's just a solid organ transplant. So that means your body's attacking your heart or your lungs or your kidneys that got transplanted. And then there's graft versus host disease, which would be more like bone marrow transplant. So that's where the bone marrow is creating new cells that are attacking the body. Our goal is to prevent acute rejection. We're going to focus mainly on renal transplant because it's the most common, but these drugs have applications throughout all transplant, and it's pretty similar. So it's got, again, broad applications, but generally the regimens aren't going to differ for different organs. So it's not like heart, we use different maintenance transplant drugs than we would for kidney. What it gets different is the procedures behind the actual transplantation of the organ during the surgical process and the preparatory process. So what drugs are we giving before we transplant? What drugs are we giving immediately after? But when somebody's on a maintenance period, that's pretty similar for the different organs we're transplanting. General strategy is to mix up mechanisms of action, which is pretty much the moral of the story throughout this entire course. When we talk about combining therapies, we like to mix our mechanisms. We don't like to give two drugs in the same class. Just like with antibiotics, we don't give two beta-lactams, right? We don't give somebody amoxicillin and Zosyn. It just doesn't make any sense. Or we don't give cefepime plus Zosyn. We combine those two. So it's the same strategy here. And this is one area which we won't really talk about too much, but specific drug levels are targeted in transplant medicine because it's so critical that the drugs succeed in preventing rejection of the graft. We need to make sure that the drugs are targeted to a specific level where we know they're going to be effective. So this is one area of medicine where we still do some drug monitoring and some drug levels on patients. This picture looks weird because I actually scanned it in from a textbook, but I liked it, so I couldn't really find anything better. And I don't want to make my own, so here we go. CD4 T cells. A drawing. This is similar to the drawing I showed you at the very beginning of the lecture, but it has a few other things to it too. So again, you can refer back to this if you're looking for mechanisms of action. One thing I'll just clarify, MMF is mycophenolate mofetil, which is a drug called Cellcept, which we'll talk about in a slide here. But in case you're referring back to this and like, I can't remember what that abbreviation is, that's mycophenolate. And you can see we have a number of different things that work in certain areas. So this should help you maybe from a studying perspective. So for example, we have three major tiers of drugs we're using for anti-rejection. We're using a calcineurin inhibitor, we're using a steroid, and we're using either MMF or azathioprine, which are anti-metabolites. So these are interchangeable, and the steroid's on its own island. So that maybe gets you to a certain point right now. If you're reviewing this from a mechanistic standpoint, you can put those into different categories. And of course, we're going to talk about this in more detail right now. So again, our three major categories: anti-metabolites, calcineurin inhibitors, and glucocorticoids. Glucocorticoids, easy to remember because it's always prednisone. Unless you're giving somebody IV glucocorticoids for some reason, you're going to be giving prednisone. So there you go. One total class out of the way right off the bat. There's some other ones which we'll talk about too and where they fall into play, but let's start with the common ones. So anti-metabolite, pretty much everyone who gets transplanted will be on an anti-metabolite. What they do is inhibit synthesis of DNA, RNA, and proteins, and interfere with cellular metabolism and inhibit mitosis. So it's preventing your T cell from pretty much doing anything important. Azathioprine, or abbreviated AZA, in transplant, they use these three-letter abbreviations a lot, so I put them on here, and I put the brand names on here. And you can put MMF on here too for you guys. Okay, so azathioprine, the historical gold standard, has been used for a long time. You're not going to see azathioprine started on new transplant patients a lot. What you might see it on is somebody who's been a long-standing, maybe they've got a transplant 30 years ago. They're probably on azathioprine. And why haven't we changed them over to mycophenolate? Well, because azathioprine's working for them. They're tolerating it well. There's really no reason to do so. Mycophenolate is more specific. It has less side effects, and it also comes as an IV formulation as well, which can have some advantages. So if you have a patient who's critically ill, gets a pneumonia, they're in the hospital, or for some reason is having problems with oral intake, mycophenolate can be a really good drug because you can get their levels back up to normal with an IV product quickly, where you can't really do that with some of the other medications we use. Both of these drugs are very effective. Azathioprine and mycophenolate are equivalent. Mycophenolate's not more effective, it's just generally better tolerated. So when you talk about tolerability, what effects are we talking about? GI effects. You want to take azathioprine with food and avoid aluminum, magnesium with mycophenolate. So aluminum and magnesium products, you're like, what are those? That'd be like things like Maalox or Gaviscon, some of those OTC GI-related not supplements, but remedies or whatever you want to call them. Those can have those products. Those can have those aluminum, magnesium in them. So make sure you tell patients to watch out for those if they're going to be taking those concurrently. But that's really the biggest thing. So GI effects like diarrhea, nausea and vomiting, things like that can cause tolerability issues for patients taking an anti-metabolite. Again, Cellcept is better tolerated than azathioprine. But on the flip side, if you tried somebody on Cellcept or mycophenolate and they didn't tolerate it very well, you could flip them to azathioprine and see. I mean, granted, the odds of you getting good response from that, if they got intolerability to mycophenolate, probably pretty slim, but it might be worth a shot. And we'll talk about another option for these in a second here. Hematologic problems, you can get leukopenias, anemias, and thrombocytopenia. This is the big difference, I think, between mycophenolate and azathioprine. Azathioprine will have much more pronounced hematologic effects. They both, you could maybe say they have somewhat equivalent GI effects. Both aren't great, but as far as hematologic goes, that's where azathioprine is going to take the cake. Oh, I put a picture down here of mycophenolate. Mycophenolate is kind of weird where different strengths come in different products types. So the 500 milligram comes as a big tablet and the 250 comes as a capsule. Why they did it that way, I have no idea. But in case you're ever reviewing somebody's meds or you work in transplant, you're like, why do you have capsules and tablets? And I don't really get it. Just know that they're the same thing, but that's just how they're packaged for some reason. All right. Calcineurin inhibitors prevent the upregulation of IL-2, which inhibits activation of resting T lymphocytes. This is our second major class we use to do as an anti-rejection medication. And there's two drugs here, cyclosporin and tacrolimus. Cyclosporin comes as a bunch of different formulations, but basically there's modified cyclosporin and then there's Sandamine. Sandamine was the first product, and it's thought to be mostly inferior. You shouldn't really see people on Sandamine anymore. You might every once in a while see them. The reason I use the brand names of these is because Sandamine still is a brand name, and it's with cyclosporin, you can get into trouble easily. So let's say you have a new patient coming into your clinic and you're putting their med list into the computer and you type in cyclosporin. You pick Sandamune when actually they're on Gengraph. Well, that's where the brand name could come into handy, because if you typed in Gengraph to begin with, you probably would have gotten the right product. So just know that this one can be kind of tricky. I'm not going to test you on the differences between cyclosporin formulations, but just know that Sandamune isn't one we really use anymore. And Gengraph and Neoral are both considered modified. The bioavailability of them is substantially better. That's one of the biggest differences between the two, between the modified and the unmodified. It's not like one's really better tolerated or better, more effective. It's just much more bioavailable, which means by default, it does actually become more effective because you get better levels in the blood. Tacrolimus is Prograf. Prograf comes as a twice-a-day capsule. Historically, there's been recent developments with Prograf. We've got a couple new extended-release once-daily products on the market. And interestingly enough, so the company that made Prograf came out with a new once-daily extended-release capsule right when their product went off market, which is pretty common for drug companies to say, hey, well, we have this new formulation ready to go all of a sudden. Great. But this other company came out with a tablet that's extended release that is actually way cheaper than the Prograf brands. So there's some interesting economics at play here, which again, I'm not going to test you on this, but it's just interesting to know that these medications aren't really cheap by any means. They're super expensive compared to some things, but if we can get cheaper alternatives, like some institutions are switching to these generic alternatives, which is really helping patients and helping keep costs down for these centers that do lots of transplants. Big one here at the bottom. Both are CYP3A4 metabolized. So we talk about drug interactions. A lot of times I'm like, well, I'll say drug is prone to drug interactions, but clinically it might not be that big of a deal. In this case, it is a big deal, because if you fluctuate those blood concentrations, even a small amount, you can possibly risk rejection. So whenever you're dealing with a patient on a calcineurin inhibitor, so anybody who's got a transplanted organ basically is going to be on one of these two drugs, you have to make sure you're really doing your homework and due diligence whenever you're prescribing a new medication. You have to be able to understand those drug interactions and whether or not they're going to affect it. Because if you give somebody a really strong inhibitor and their concentration goes through the roof, they could get really bad side effects. They could get really bad toxicity. Or worst case scenario, give somebody a strong inducer of the CYP system and their concentration drops, and then they end up with rejection. That would be terrible. So we have to make sure we're being vigilant on drug interactions with transplant patients. That's a non-negotiable. It's certainly a very important part of this. Adverse effects. So these are the shared adverse effects between the two. Nephrotoxicity is the one we're most worried about, and especially if you think about like a kidney transplant population, of course, it's a big concern. Tremors, hypertension, hyperglycemia, but nephrotoxicity is really the big one here. CSA is cyclosporin abbreviation. Why CSA? I don't know. That's how they abbreviate it. Can cause some hyperlipidemia. It can cause gingival hyperplasia, which sort of gums kind of overgrow your teeth, and hirsutism as well. Some undesirable side effects there. Tacrolimus is maybe a little bit better tolerated, but it does have some nausea, diarrhea associated with it. It can be hepatotoxic, rarely, I should say, and can cause some electrolyte disturbances with increasing potassium and magnesium levels. Usually not too bad. GI is probably the one patients will complain about the most, and of course there's some labs that you could run to test for hepatic issues or electrolyte imbalances. All right, and then glucocorticoids. We talked about prednisone already. Usually it's just a once daily small dose of prednisone. It's like 5 to 10 milligrams a day for most patients, and it's an augmentation of the rest of this. So it's a third mechanism of action. You're getting your full immunosuppression. But just remember that these patients are going to be on these medications for life. So we try and keep the prednisone dose as small as possible with also being effective. Now, the issue is you get long-term side effects. So hyperglycemia, you get mood changes potentially, you get GI bleeding issues with long-term use, you get thinning of the skin, impaired healing, stuff like that. So that's something transplant patients unfortunately kind of have to live with. Can people get by without the steroid if they have to? If somebody has really bad reactions, like maybe psychosis. Let's just throw it out there that they get maybe the worst, maybe they basically become a schizophrenic on a steroid. It's possible. Can you skip the steroid? Maybe. I'm not going to recommend that. It's a cornerstone of therapy, but if somebody is not tolerating it at all, you might have to trial that. So it's tricky when you talk about a transplanted organ because so many resources have gone into getting that organ transplanted. Somebody donated an organ, somebody had to do a 12-hour surgery to get that organ into there. There's a ton of prep and ton of education. There's a lot of personnel that have to walk you through that process as the patient. So to have that organ reject is a really bad thing. So ultimately we have to weigh the pros and the cons, but sometimes you run into these issues where these side effects are really nasty, and you have to do what you have to do, but you try and work best for the patient. What's best for the patient. mTOR inhibitors are a sort of fourth class, and they are a fourth class. And they are, mTOR is mammalian target of rapamycin, and what this is it's a specific target that inhibits T lymphocyte activation and proliferation. What we use these drugs for is a replacement for calcineurin inhibitors that with patients are having risk for renal toxicities. Somebody is on a dose of tacrolimus, and it's causing increases in serum creatinine. Their recent kidney transplant or heart transplant or whatever it might be, it doesn't really matter, but let's say we see some early signs of kidney failure. That's going to be somebody who we might switch them off the calcineurin inhibitor and put them on an mTOR inhibitor. So sirolimus and everolimus, Rapamune and Afinitor, are the two drugs here. You can also use them to replace the anti-metabolite. So they have a totally different mechanism than either calcineurin or anti-metabolite. So most commonly, again, people fail the calcineurin inhibitor because of that nephrotoxicity component, but people also fail the anti-metabolite because of the problem with GI side effects. So either one of those happens, you have this sort of as a backup class. It's not a first-line drug. You don't use it first line in any case. They're usually more expensive than the other ones. They haven't been around quite as long either, so I don't think there's as robust of data associated with their efficacy. However, they are effective and they are a good alternative if you have to use them. Problem is, hopefully you don't ever run into the worst case scenario where somebody has nephrotoxicity and they have terrible GI effects, and then you're just going to have to play with doses to get something to work. But at the end of the day, this can serve as a replacement for either one, but more commonly the calcineurin inhibitor. Adverse effects, hyperlipidemia and some blood dyscrasia type things, maybe some peripheral edema too. Okay, that's our maintenance regimen, and that's going to be the most critical drugs to understand. We're going to talk about some of these more complicated medications, but as far as testable material, I really want you to focus more on the maintenance thing. I might ask a question or two about the next few drugs we talk about, but really this gets much more into detail about things like if somebody's organ rejects, what do you do? And again, I might ask a question or two about that, but a lot of it's protocol driven depending on what institution you're in. So if you work at a big heart transplant center, if you have somebody coming in with rejection, they're going to have a specific protocol outline. Okay, we give this person this much of this, we give them this and this and this, and we're going to try and get the rejection under control using this strategy. It's not like, well, let's go to Chad's lecture and figure out what we should do. You don't really do that in this case. Most of these places have these really, again, stringent protocols in place where they follow them to a T. So IL-2 receptor blockers prevents activation and proliferation of T cells. We use this for induction only. Induction is prior to transplantation, we suppress the immune system to prevent any type of rejection immediately from occurring. So can't rely on those oral medications that we just talked about getting to the right concentration by the time we need them to. So this is sort of an insurance policy, if you want to look at it that way. These are really expensive, but you only use like one dose of them. In the grand scheme of a kidney heart transplant, nothing. You know, we call these expensive as far as medication goes, but when we're talking about a transplant heart, that's what, I don't even know what that costs. Millions of dollars, probably. Who knows? I'd say at least $1 million. So extremely expensive, shown to significantly reduce rejection, thought to work on active T cells only. Not really any adverse effects. These are both monoclonal antibodies, so they're biologic products. Biologic products rarely have side effects because they don't really do anything other than get to their targeted site of action. The big side effects you get are hypersensitivity reactions and injection site issues. That's really it. Other agents. So these are agents we usually use for either, maybe they might be used for induction in some places and maybe for acute rejection. And we'll talk about where this sort of fits in the next several slides I'm going to show you. But rituximab is a product that inhibits B cell proliferation for about 9 to 15 months. It's used in a number of different autoimmune and chemotherapy applications, but it applies here too. Alemtuzumab is Campath, which I think of like as a nuclear weapon that destroys any T and B cells your body has, wipes them out for 6 to 12 months. It's used for lymphocytic leukemia. I can't talk today. OKT3 is a product that depletes T cell concentrations via specific CD3 receptors. Thymoglobulin, there's a couple out there. The more common one is RADage or rabbit antithymocyte globulin, and that interacts with T cell surface antigens and depletes CD4 lymphocytes. Bortezomib is a new medication. Let me correct my spelling there. Bugging me. Bortezomib or Velcade is approved for multiple myeloma, and during the chemotherapy I talked about those tyrosine kinase inhibitors. This isn't really a tyrosine kinase inhibitor, but it's kind of in the same family. It inhibits proteasomes, which is an enzyme complex resulting in regulation of protein homeostasis in cells. So what this does is it allows your body to more effectively kill rogue cells, which for multiple myeloma you have cells that are possibly producing proteins at a really fast rate that general chemotherapy can't keep up with. This drug works a little bit differently. For transplant medications, this is more of a new emergent therapy. I'm not exactly sure where it fits in. I know we've been doing some clinical trials on this at Abbott, but this isn't my area of expertise, and again, I don't really want you to know too much about this because this isn't super important. Okay, so I know I said I'm not going to ask you a lot of questions on induction or rejection, but there will be a couple, and I want you to know the basic strategies. So, because I think it's important to understand, we talked about maintenance therapy at the beginning. That's what happens after transplant, right? In between your clinic visits and all that thing. That's what the patient's doing for the rest of their life, which is why it's really important to talk about. But the rest of it is, I think, worth explaining to you. So induction therapy can sometimes be controversial. And it depends on the organ. For like kidneys, it's pretty much a guarantee that they're using induction therapy. Heart transplantation, there's been some controversy over whether inducing immunosuppression in somebody is beneficial or not. There's a lot of evidence that says that there's some evidence that says it might be, some evidence says it's not. It's kind of mixed. So again, what I said about centers having specific guidelines for this applies here. A center will have a guideline that says we do induction or we don't. That's just what the transplant committee, the surgeons, the physicians, and all the experts are going to have to weigh in and say, okay, we should do induction, and this is the induction process we do with every transplant. So again, it's going to be institution specific. So if you're going to induce, let's say you are, alemtuzumab, rabbit antithymocyte, globulin, IL-2s, or rituximab are usually the drugs you're going to look at using. Also, all patients are probably going to be at IV methylprednisolone, a pretty high dose. We're talking about like 10 times what you'd give somebody for an asthma exacerbation. You might give somebody 125 milligrams IV if they have asthma exacerbation. You probably give somebody 1,000, maybe more, for one of these. After that, you're ready for your transplant. That's really all induction is. It's 2 doses of medications. You're going to give one. Whoops, my slides are moving all over the place here. All right, let me fix this quick. You get one from column A here and one from column B, and you go to your transplant. That's really all there is. Maintenance therapy, talked about this. You've got your maintenance regimen, which consists of your calcineurin inhibitor, your anti-metabolite, and your steroid, maybe with some tweaking depending on what type of side effects you're getting, maybe an mTOR inhibitor if you need to. You're going to monitor your patient at determined intervals. You're going to test blood concentrations, make sure your dose is correct. Everyone metabolizes medications differently. Some people will need small doses, others will need large doses. That's why we do serum levels to get that concentration honed in so that we know exactly what serum concentration we're looking at and we can target that specifically. Is rejection occurring? That's something that we're going to be able to measure in some cases. So for example, if you have a kidney transplant, you can see if there's a spike in serum creatinine that could show you acute kidney failure potentially. Cardiovascular, you could see maybe increases in troponin elevation, but you ultimately can have to biopsy people, and we'll talk about that too. And rejection is treated based on organs, treated differently if you have a kidney failure, if you have a heart failure. Kidney and liver rejection is lower acuity, I should say, than cardiovascular or pulmonary rejection. So let's say your labs show rejection. You have elevated liver enzymes, you have elevated serum creatinine. You're going to adjust your maintenance regimen empirically. For the most part, you're just going to give somebody increased doses of what they're taking. Make sure they're being compliant. Are you being compliant with your cell steps? Have you missed doses? Like, is there something wrong with the way you're taking your medication? Are you experiencing side effects? Those are important questions to ask. And if not, maybe you increase the dose. Check some other blood levels, see what you need to do. Do your research that way and figure out how to address the patient best. But you really don't have to do much more than that. If the empiric regimen adjustments don't show some resolution soon, so you don't see things start to trend in the right direction, you're going to move to your heart rejection algorithm. Heart transplant, I think you put a lung transplant in here too. I'm not exactly sure. We don't do lungs at Abbott, so I don't know exactly what they do, but I'm assuming it's pretty similar to heart. Be more of a high acuity thing. So in this case, if you're suspecting rejection, you do a biopsy to confirm that there's some cell death going on. Rejection classified as mild. So again, this is not my expertise. Pathology would say this is mild rejection or moderate to severe rejection. If the rejection is mild, you're going to treat with a burst of steroids. So you're usually going to give IV methylprednisolone, dosing, again, dependent on institutional policies. If that doesn't help suppress the immune system enough to prevent rejection, you're going to proceed to the moderate treatment algorithm, which is going to be steroids plus something else. So usually you can give rabbit antithymocyte globulin, you can boost somebody's tacrolimus or mycophenolate, IV. Tacrolimus and mycophenolate both come as IV products, so you can give somebody some of that to increase their serum concentrations briefly. Rejection still occurring, we're going to use some of those big guns we talked about, either alemtuzumab, rituximab, OKT3, bortezomib possibly too. Those are a number of different options we have. Again, not a lot of questions on that whole process. I'm not totally concerned you know it. I would be able to recognize like what an IL-2 receptor inhibitor is, which one of the two is that is. And then if I ask you a rejection question, knowing if you use steroids, I might ask you a compliance question about maintenance regimen, something like that. But for the most part, very minimal part of the exam for those last couple slides there. So with transplant, compliance is really a big deal. There are patients that unfortunately we can't transplant just because they won't be adherent. If they have a long-standing history of non-adherence, which might be why they got to the point where they need a transplant to begin with, it's not going to work out for anyone if we transplant that patient. That patient's going to go through rejection. They're going to get an acute graft failure, they're going to be in the hospital for a long period of time. And not only is it detrimental to the patient, it's really expensive. We are investing a ton of resources. And this is a transplanted organ. Somebody probably, like the case of a heart, somebody died to supply that organ. We really want to make sure we're using it in the best candidate possible, somebody who has absolutely flawless adherence rates and is not going to be somebody we have to worry about too much. You know, if we're transplanting people who are going out and doing cocaine or doing drugs and not taking their transplant medication, that's just a total waste of everybody's time. So this is really important. Certainly you can educate people, try and get them on board beforehand, but you really need to be on board beforehand and not after. You can run into big issues with that. Medications aren't cheap. Most insurances pay for them, so it's not a huge deal for these patients. Most people aren't paying cash out of pocket for this stuff. Most people have insurance of some kind, or they have an assistance program to help them. But they aren't cheap. They're somewhat expensive. They're cheaper than they used to be. Mycophenolate's gotten generic. Tacrolimus is generic now. So all those drugs have gotten less expensive over time, but still not, not like a really cheap anti-blood pressure regimen. And also you have multiple drugs to take a day. Not only do you have all these medications, but think about all the other things you're probably taking too. So let's say it's a heart transplant. There's probably a lot of cardiovascular medications associated with that transplant too that you're on. Kidney transplant, probably other things you're taking as well. So a transplant patient's probably going to have a solid 15 to 20 medications they're taking on a daily basis. So while the core regimen's 3, you still have a lot more to consider as far as their entire regimen they're taking. Let's see. Consistent timing of doses. So people need to take these medications consistently, and that's like you set your alarm for 8 a.m., 8 p.m. at night, or whatever it is, 12 hours apart for your twice daily meds, and you're taking them on the hour at that time. It's really important. Keep your blood concentrations nice and steady. That's really key with this. Many additional drugs to prevent adverse drug event. So I talked about the drug regimens. We talked about maybe some supplemental things depending on what specific diseases the patient has, but opportunistic infections are important to consider too. These patients are immunosuppressed, so things like oral thrush is an issue. Skin and soft tissue infections can be an issue. Malignancies like skin cancer can be common. Osteoporosis can be common with the long-term steroids. They'll often be on various medications that help to prevent these things. They might be on some prophylactic antibiotics. They might be on osteoporosis-related medications too. And frequent monitoring required. These patients need to live close to a transplant center. They need to be able to follow up regularly, and they need to be able to keep their appointments. You have to have people who can get to a transplant center fairly quickly if they do have rejection, so that they can get into surgery or whatnot, get evaluated quickly and triaged appropriately. And I talked about this a number of times, but a lot of what I said today is pretty standard in the industry, but some of it might differ wildly depending on what institution you go to. And that's definitely going to be on the induction and rejection side. So you might read this and be like, well, we don't use any of these drugs at my kidney site. Well, sorry. I'm just trying to give you the more general approach to what we do. But again, protocols can vary depending on what institution you're working at. So, all right, that's it for immunosuppression and transplant, and I will see you guys in a week.